All right, we're ready to get started with our third speaker. During one of our past events, I forget what the topic was, but I was getting questions that the audience was getting up and asking questions about drug shortages and about issues relating to availability of drugs and prices, and the topic of the conference wasn't even about drugs. So I realized that this is an issue that has not been addressed, and we really do need to be looking more closely at drug policy at the Baker Institute. So we're delighted to be able to have an expert on that particular issue today. David Howard is an associate professor in the School of Public Health at Emory. He's visited Rice before and spoken with people in the economics department. He is widely regarded as an expert in just generally in terms of cancer policy, not just in terms of drugs, and he's also contributed a lot in terms of the literature that we know about the transplant, issues of access to transplants in this country. But today he's going to be talking with us about pricing anti-cancer drugs.
All right, thank you to Vivian and the Baker Institute for having me. So we're going to go from talking about a market with limited competition to markets with no competition, so the drug markets. My research has been conducted in collaboration. I'm going to present some research results today, and I want to acknowledge the people I've collaborated with. Did I just... Oh, there we go. Okay. So Rena Conti, Ernie Berndt, Peter Bach, I'll tell you why he's up in a minute, David Grabowski, Michael Chernew, Tamer Abdeglawat. So it seems like not a day goes by now where there isn't a headline about drug prices, about issues related to restraining drug pricing. Hillary Clinton and Bernie Sanders have been predictably critical of the drug industry, but now this last week even Republicans have gotten on board. So at a town hall event in New Hampshire, Marco Rubio was asked about drug prices, and he came out and said that what drug companies are doing is pure profiteering. This is going to threaten to bankrupt our system. And of course we all know about this guy, Martin Shkreli. So he was he noticed that there's this drug being sold called Daraprim. It's an older anti-infective drug, but there's only one, so it's long off patent, but there's only one company making it. So he acquired the company and raised the price by $5,000. And then there's other companies that have been engaged in this too. But today I'm mainly going to talk about, and of course the upshot of all this is that although the biotechnology sector and pharmaceutical companies in general have been attracting a lot of interest from investors, a lot of funds flowing into that sector, as a result of all this criticism, stocks for these companies have tanked. There's a lot of fear that this time, although there have been many instances in the past where politicians have criticized drug companies, including many coming from Hillary Clinton, this time it's going to be real. This time there are going to be real consequences, real actions taken. But that remains to be seen. I'm going to talk today mainly about the market for anti-cancer drugs. I think some of what I'm going to say carries over to the market for other types of drugs, but the market for anti-cancer drugs is unique in some respects. What got me interested in the market for anti-cancer drugs is that I think, although in healthcare and health economics, we talk a lot about kind of trade-offs between life and money, between health and money. In the case of anti-cancer drugs, which are primarily used to treat patients with late-stage cancer for whom drug therapy is the only option, and drug therapy prolongs life, but it's not a cure for cancer. In this setting, the trade-off between money and health is more explicit and more concrete than it is in other instances that we talk about in healthcare. Also, it's financially significant. Spending on anti-cancer drugs in the US was $37 billion in 2013. There are over 900 anti-cancer drugs in the pipeline for approval, more than the number for heart disease and mental illness combined. This is an area, like the biotechnology overall, that's attracted a lot of interest and a lot of funds from investors. It's also symbolically significant. when people look to say, how is our healthcare system doing? How does the U.S. healthcare system perform relative to other healthcare systems? One of the areas where they look at is cancer survival rates. And so there have been many instances where politicians say, well, yeah, you might think Britain does a better job or is no worse than the U.S., but in fact, if you look at cancer survival rates, because patients in the U.S. have better access to anti-cancer drugs, patients in the U.S. live longer. I don't think that's an accurate comparison, but that's for an epidemiology class. So what I've done is to gather with collaborators is to gather data on 58 anti-cancer drugs that were approved by the FDA between 1995 and 2013. These drugs are all intended for patients with late-stage cancer, so there's only one of the 58 is anything close to a cure for cancer. The rest prolong survival for most drugs between 3 and 5 months. What we did was we collected, we priced out these drugs. So that when I talk about the price here, I'm talking about the launch price, the price that the company sets on the day the drug is approved by the FDA. What we did that I think was kind of unique compared to a handful of other studies in the medical literature that have attempted to look at trends in drug prices for anti-cancer drugs was we looked at not only kind of the monthly price or the price per year, but we looked at the price per episode given how long the patient will typically take this drug. So this turns out to be important that there's some drugs that a patient may only take for 2 months, some drugs that patients may take for 6 months or longer. So this is really important for getting an accurate estimate of the price of a drug. And so there's this quote I saw. James Caruso, who's an executive at a drug maker, was asked about the high price of his company's drug, and he said the price of Fallon was not out of line with that of other drugs for rare cancers. Patients, moreover, are likely to use the drug for only a couple of months because the tumor worsens so quickly. So I saw this on an economics blog called Marginal Revolution, where it was termed the least convincing argument of the day. But there is some truth to that. So here are the main results. So each dot here represents a drug, a newly approved drug. The dots are different colors, indicating where we pulled information on the benefits of the drug from. On the x-axis, you have the year the drug was approved. And so we're looking here only at the initial indication for which the drug was approved. Some of these drugs are subsequently approved for other tumor types. And on the y-axis, you have kind of a measure of the cost effectiveness, although I don't want to call it that because there's a lot of stuff we're not taking account of here. But basically, we take the price of the drug, which represents the amount that Medicare would reimburse providers for these drugs, and divide it by the gain in overall survival or progression-free survival or average survival if it's available from a modeling study. So what we see, I mean, there's a lot of variation even within a point in time, but there has been an upward trend in drug prices over time. So we estimate that that prices are going up, the launch prices are going up after adjusting for benefits by about $9,000 per year, or about 11%. So we want to try to understand, what's going on here. What would allow this dynamic to persist? And it's interesting, kind of looking at some of the press coverage today. A lot of the same arguments are being lobbied at drug manufacturers that these arguments have been recycled. So in 2004, there are 2 drugs approved for colorectal cancer, bevacizumab and cetuximab, that attracted a lot of attention. There was a concern among Wall Street analysts that based on the high price of these drugs, Congress was going to step in and finally do something about drug prices. And as a result, there was a lot of pushback. But the thing is that these drugs were priced at about $50,000 per patient. The drugs that are being approved today and that are attracting a lot of attention are priced at $80,000, $100,000 or more per patient. So you kind of see how the arguments keep being recycled, but there's kind of a different baseline for judging what is and what is not an unreasonable price. So in terms of thinking about what's going on in this market, how can we understand pricing behavior in this market? There are a few features that I think are kind of unique or distinguish the market for specialty drugs and then anti-cancer drugs from other markets in healthcare and other markets in general. So first of all, producers are monopolists. These drugs have patent protection, at least for a limited period of time. And even for drugs that are patent protected, in other pharmaceutical markets, sometimes drugs can be therapeutic substitutes. With cancer drugs, that's generally not so much the case. These drugs tend to be used in a sequence of treatments such that even if you can use 2 different drugs to treat the same patient, you might use drug A and then drug B or drug B before drug A. So they're not really competing with one another. Also, for all the grief that insurers get in the media, they cover all anti-cancer drugs on the day they're approved by the FDA. They cover them regardless of price. I'm unaware of any instances where an insurance company has refused to cover an anti-cancer drug because it costs too much. They may try to limit its use. They may try to make sure that physicians only use the drug for FDA-approved indications, but it's always covered for some group of patients. And then physicians, so some of the drugs, and increasingly this is true, some of the drugs are oral drugs. They're drugs that the doctor writes the prescription and the patient picks it up at the pharmacy. But many of these drugs are intravenously administered. They're administered in physicians' offices or hospital outpatient infusion centers. And so that means the physician or the hospital buys the drug and then they turn around and bill insurers. Consequently, they make money on these drugs. They make a lot of money on these drugs. Even though Medicare has tried to take steps to tamp down reimbursement, oncology practices still derive a large share of practice revenue from these drugs. So physicians have little direct financial incentive to avoid using a high-cost drug. And in fact, they even make more money on high-cost drugs. And then patients face low cost sharing at the margin. So there are many patients who go bankrupt trying to finance their cancer care. But on average, cancer patients pay only a very small share of the cost of these anti-cancer drugs. And to the extent that could potentially limit patient access, to the extent that could potentially make it more difficult for pharmaceutical companies to charge higher prices, pharmaceutical companies have come up with a clever way to try to subvert insurers' cost-sharing mechanisms, and that is to operate patient assistance programs. So if you're a patient who requires one of these drugs and you have private insurance, you can apply to one of these companies' programs. And now all drugs that are approved have programs associated with them like this, where you basically tell the company, my insurer is requiring me to pay $100 every time I get this drug, or $2,000, I'll have to pay $2,000 for the first 6 months of treatment. And the drug company will basically refund the co-payment, refund the deductible, refund the co-insurance. Whatever the patient has to pay, the company will basically refund that money. So patients, privately insured patients, pay very little out of pocket for these drugs. These programs, by law, are not allowed to provide assistance to Medicaid and Medicare patients. However, many Medicare patients have generous coverage on top of Medicare that covers co-insurance. And there are independent foundations that are funded by pharmaceutical companies that help Medicare patients with some of these costs. So, all this describes kind of the features of the market, why pricing in this market is unique, but they don't necessarily describe why prices have gone up over time. So here's one theory about why that might be the case. So here's what I think is going on. So in the words of the 46th governor of this state, oncologists are really the deciders here. They're the ones who are making the decisions about what drug to use. So that's really the audience or the customer you want to think of. As I said, they have no direct incentive to avoid high-cost drugs. However, they may balk at prescribing drugs with prices they perceive as unreasonable or unfair. So here's kind of the key. The next one is kind of the key point. Perceptions of unreasonableness are malleable and influenced by the prices of previously approved drugs. So in the marketing literature, there's a concept called reference prices, which is that when consumers look at a price and say, do I want to buy this product or not, they kind of compare it to the prices they've seen before or prices of similar products and use that as kind of a basis of comparison. So what I think is going on here is that when a company comes in with a price, sets the price of their drug at X, the next company to enter has a little bit of leeway to set their price at a little bit higher than X without incurring any type of backlash or without reducing demand for their drug. So I think there's kind of been an upward spiral of drug prices that, because of the unique features of the market, because none of the customers here, either patients or providers, have financial incentives to avoid high-cost drugs, this cycle can persist. And in fact, if you look at the trade press, if you look at comments from drug executives, they're all kind of consistent with this idea that when deciding what price to set for a new drug, they kind of look at the prices of existing drugs and set their price a little bit higher. So when pharmaceutical manufacturers are asked to justify the price, they always make some statement to the effect of, well, yeah, our price might be high, but look at all these other drugs, our price isn't that much higher than that. And in some cases, they're even referring to drugs that are not, that are from completely different tumor types, so there's no way that they're competitors. Here's a quote from an oncologist describing drug pricing in this market. Right now it's basically chutzpah. The most powerful predictor of the entry price is the entry price of the drug that came before it. And there even been, I'm going to skip over it, but there's a quote from a Wall Street analyst who talked about when bevacizumab entered the market and people thought, oh, wow, that's such a high price, that kind of price is unprecedented for an anti-cancer drug. He talked about how for drugs that were about to be approved, for drugs that were on the horizon, the fact that bevacizumab had come in at such a high price was basically going to increase profits for these other drugs, because it had kind of like pushed the envelope. It had pushed the bounds of acceptability so that these other drugs could come in at higher prices. What happens when a company pushes too far over this envelope, when they price a drug that people think is unreasonable, is illustrated by the case of the drug Zaltrap. So this was a colorectal cancer drug that its closest comparator was bevacizumab. Zaltrap was priced at about, I think, 100% more than bevacizumab. It's a little unclear whether the company did this on purpose or when calculating the price of bevacizumab on which to base the price of Zaltrap, they simply used the wrong dose of bevacizumab. That's what the company said. But either way, Peter Bach and his colleagues, who are prominent oncologists at Memorial Sloan Kettering, wrote an op-ed in the New York Times with the long and the short of it is, your drug is priced too high, we're not going to use it. And as a result, the company cut the price of their drug in half a few days later. So this kind of stuff, pharmaceutical companies are very attuned to this kind of backlash and not wanting to provoke one. Another thing that's going on in this market, which is driving up drug prices, which one of my co-authors, Rena Conti, has done a great job of pointing out, is growth in something called the 340B drug pricing program. So I didn't know much about this program when I started studying this issue, but it's kind of an interesting little program that no one outside of the pharmaceutical industry or oncology is very much aware of, but it's really important. And so this is a program that was designed to allow providers that take care of mainly indigent patients to get discounted prices on physician-administered drugs. So like most government programs, it started off with the best of intentions, but over time it became something other than what it was intended to be. The number of providers who are eligible for 340B discounts has increased over time, both as a result of regulatory action and as a result of mergers between providers who qualify for 340B drug discounts and providers who do not qualify for 340B drug discounts. So for example, the University of Michigan is a 340B provider. They qualify for these very large discounts. And when Medicare sets the prices or reimbursement rates for drugs, they don't take these discounts into account. So 340B providers earn very high profits on physician-administered drugs. So as a result, as more providers are eligible for these discounts, companies face an incentive to set higher profits to basically kind of offset the discounts to the 340B segment of the market. And the reason for that is that the prices in the non-340B segment and the 340B segment are linked, such that the discount is set as a percentage of kind of the top line or list price. So there's inherent incentive with the 340B program as the number of providers increases, as the share of the market that goes to 340B providers increases, companies will set higher prices. I'm going to shift gears now and talk a little bit about some other work I've done with Michael Chernew, David Grabowski, and Tamer Abdulgawad on looking at outcomes in cancer patients. So this is kind of getting at the question, all right, we know these drugs cost a lot, but really what's the value here? Are we seeing clinical benefits that are proportionate to the cost? So what we've done is to look at Medicare patients diagnosed with late-stage cancer in a few tumor areas, and we've looked over time, and we've simply said, all right, what has happened to cost for these patients? What has happened to life expectancy? And let's look at the change in cost. Let's look at the change in life expectancy and see, is there some balance between the two? So this graph shows survival curves for women Medicare beneficiaries, female Medicare beneficiaries diagnosed with late-stage breast cancer. So there are 4 curves here. So the groups here first split based on when the patient was diagnosed, either 1995 to 1999 or 2005 to 2011. They're also split based on whether the patient received any form of chemotherapy or anti-drug therapy or anti-cancer drug therapy or no drug therapy. A surprisingly large share of Medicare patients diagnosed with cancer of any type don't receive any treatment. Some go straight to hospice, others I don't know what happens, but they don't get treated. But what you see is the shares of women receiving in each of these groups, either the drug therapy or no drug therapy group, hasn't really changed much over time. And so what we see is that for women in the no drug therapy group, the survival curves almost lie on top of each other. There's basically been very little improvement in survival times. But for women who are receiving drug therapy, you see that the survival curve, the red survival curve is, upward shifted relative to the blue survival curve. So there have been real survival gains in this patient population, and it's hard to say, what else could account for these gains other than the availability of new anti-cancer drugs. And so using some techniques for kind of projecting life expectancy and lifetime medical costs, we calculated for each patient group the months of survival that were gained between patients diagnosed in the period 1995 to 1999 and then 2005 to 2011. So for example, for breast cancer patients who are receiving drug therapy, we estimate that life expectancy is increased by about 18 months. Costs have gone up by a lot. Costs have gone up by almost $100,000. But when you kind of look at the life expectancy gain and look at the increase in cost, you say, well, that's a reasonable value for the money. Based on kind of commonly used thresholds for determining cost effectiveness, we'd say, that's not a bad deal. Lung cancer, the results aren't so optimistic in terms of the gain in survival, but costs really haven't gone up by that much. With kidney cancer, you have a almost 10-month gain in life expectancy, a $40,000 increase in costs. With chronic myeloid leukemia, life expectancy has gone up by 24 months. Costs up by $100,000 because of a small sample size and the lack of prescription drug data historically. We weren't able to separate the kidney cancer and chronic myeloid leukemia patients populations into subgroups of patients receiving drugs and groups of patients who aren't receiving drugs. But if we were able to do that for CML, for leukemia, you'd see that life expectancy for patients receiving drugs has really, increased by an amazing degree. So it looks like, the conclusion we walk away from this is, maybe we shouldn't be so concerned about the price of these drugs. I mean, they are improving health to some degree. That said, a lot of the most expensive drugs were approved after the period covered by our data. So although the drugs that were approved before 2011 might, in terms of cost effectiveness, that might not be so true of drugs approved recently. So I want to conclude by talking about kind of policy proposals to address drug prices. So these are a list of options that some have been thrown around by congressional or presidential candidates. Others are things I just made up on my own, but I'll go through them. So a number of states are considering laws that would force pharmaceutical companies to disclose their spending on research and development. Massachusetts actually, this isn't in the list, but Massachusetts is considering implementing a commission that would cap prices for drugs deemed as critical to the state. Hillary Clinton suggested in a recent proposal that pharmaceutical companies be required to spend a share of revenues on research and development. I don't know where this proposal came from. I thought it was completely ridiculous. The most predictable effect here, other than creative accounting, would be that firms that sell a lot of high-cost drugs would probably merge with firms that do a lot of research and development but don't have any drugs approved yet, so they could say, aha, now we satisfy the research and development share requirement. There are a couple proposals that I think are really at least superficially appealing, but I'm not sure how effective they would be. So I think the common thread here is that people see different buyers being charged different prices for drugs, and they say, all right, well, if we just, if the buyer that's paying higher prices just does a little better job of bargaining, we could lower prices, down to the lowest price available. And so, for example, with importation, we see Canada pays less for drugs. What if we allowed people to buy drugs in Canada? Then we'd have a lot lower prices in the US. I don't think that is going to be such an effective policy. Drug makers make a large share of their profits on the US market. I think the predictable impact of allowing reimportation would be that companies would, instead of lowering prices in the US, they'd just raise prices in Canada. It's the same thing with Part D volume purchasing. That may have some effect, but drug manufacturers would rationally respond by increasing prices for other segments of the market to offset any discounts they give to volume purchasing, or to kind of increase the baseline so that there isn't such a big gap between Medicare Part D and other purchasers. So I don't know that there's really a whole lot of savings to be had here. In the market for anti-cancer drugs, there's really, as I said, very little competition, very little ability for purchasers to say, well, we're going to cover, if you don't give us a better price, we're going to cover your competitor's drug, but not your drug. They just don't have any negotiating power. So it's just not clear how either of these proposals would address the high cost of anti-cancer drugs and the other specialty drugs that are the subject of so many of the headlines about pharmaceutical prices. Another plank in Hillary Clinton's anti-drug platform was to limit patients' out-of-pocket costs for drugs. This is probably a predictable vote getter, but in terms of its impact on overall drug prices, if anything, this would make drug companies very happy. It would allow them to command higher prices because they have to worry less about the fact that if they charge a higher price, patients would use less of the drug. There's a lot of talk about tying price to value, and I'm not sure how much substance there is. Some of this is coming from the pharmaceutical companies where they say, we can't just say, listen, we're monopolists, you gave us a patent, this is the price we charge, tough. They have to come back with some response that acknowledges the public's anti-drug sentiment. And so one of the things they've come up with, instead of just charging the same price for every patient, we'll take a higher price if the drug works and a lower price if the drug doesn't. I'm not sure how this is really going to affect average prices, though. That said, there are some interesting initiatives underway that some payers are undertaking in this area. So Express Scripts is currently piloting an initiative where for anti-cancer drugs that are used for multiple tumor sites, instead of using the same reimbursement level for each tumor site, they will pay more for the tumor site in which the drug is more effective and less for the drug in the tumor site where it's less effective, which seems like kind of a sensible approach. This was an idea that Peter Bach pioneered. The FDA approved the first biosimilar earlier this year. So biologic drugs, traditionally it's been very difficult to get kind of a generic version approved. But now the FDA has come out with a pathway by which manufacturers can submit biosimilar applications. There's still a lot of rules and kinks to be worked out, however. And so I think anything the FDA can do in that regard to speed entry of biosimilars and to promote competition will lower drug prices. So that seems to make sense. Another thing this is kind of more my own proposal, but and this is more in regards to the anti-cancer drug market, but there have been a lot of drugs that have been approved recently where the survival benefit is very marginal, or the evidence in favor of survival benefits is very low. And so I think that the FDA should subject some of these drugs to a little bit more scrutiny. That I don't know that that would do anything about the prices, but at least when a drug did get approved and charged a high price, there would be solid evidence behind it. Here, I think the case of bevacizumab for breast cancer is informative. So this is based on one analysis of serum Medicare data from an unpublished study I'm working on. But in 2004, the FDA approved bevacizumab for colorectal cancer. In 2005, the first study examining the use of bevacizumab in women with metastatic breast cancer was presented at a medical conference, and use of the drug kind of took off. Although even at its peak in 2008 and 2009, no more than 18% of women diagnosed with metastatic breast cancer received bevacizumab. One of the reasons is that there are a lot of drugs approved to treat breast cancer, so none has a particularly large market share. But the FDA didn't get around to approving bevacizumab for breast cancer until early 2008. But as a condition of approval, it said we'd like to see additional data before we grant it full approval. There were 2 additional studies that were presented, the Evadote trial and the Ribbon trial. They found that the drug improved progression-free survival, but there was no data to suggest that the drug improved overall survival. And it's kind of interesting. So these studies were presented and became common knowledge, but nothing really happened to the use of this drug. I think oncologists may have been waiting to see how the FDA viewed the evidence, because it was not completely clear, because you had conflicting results for progression-free and overall survival. But the FDA initially weighed in mid-2010 when the Oncologic Drugs Advisory Committee voted to rescind approval for bevacizumab for its breast cancer indication. And there you see that's when the steep drop occurs. Use of bevacizumab in this market just dropped off a cliff. The FDA actually didn't get around to revoking approval until 2011. And it's kind of interesting, as just a footnote, almost all payers, including Medicare, continue to cover bevacizumab as a treatment for breast cancer. So, but I think, any steps the FDA can take to improve the information we have about these drugs, to promote the use of comparative effectiveness research, to provide incentives for undertaking comparative effectiveness research, is going to help improve kind of the efficiency of the use of these drugs, although it may not do much about prices. That's it.
So I think when economists think about this problem, there's basically one possible correct argument for why prices potentially should be high, and that's to incentivize R&D, to incentivize firms to develop drugs whenever the total surplus exceeds the expected costs of developing those drugs. So do you have a sense, like, if we could find a policy that would reduce prices by 50%, do you feel like from that perspective, from the perspective of long-term R&D, that that's something we should do because, for example, due to business dealing and insurance, there's too much R&D being done or too many bad drugs being created? Or do you think that that's something we should shy away from because that would disincentivize lots of good drugs from being created?
Right. So there's no question, it's a good question, and drug companies will often speak of, we charge higher prices because we have to fund R&D, but really, the causal relationship is the reverse. The reason that there's so much investor interest in this segment of the market is because they see these drugs coming out and commanding very high prices. That said, I think the segment may be due for a little bit of a correction because there's so many anti-cancer drugs coming online that the period when a given drug has to earn profits before it's replaced by a superior product is becoming increasingly narrow. I guess it kind of goes back, that's kind of the question we were trying to get at with this study is, all right, let's look at what's happened with the drugs that have been approved previously. Are they providing good value for the money? And at least based on this study, we'd say, yeah, they're providing good value. But, I don't know. It's hard to say. I mean, I think on the one hand, it may be the case that there are all these drugs being approved now, which, individually you look at their survival benefits and it's like 3 months, 4 months. I mean, it's not, not the revolution we're hoping for. But maybe the stock of knowledge that's being built up through clinical investigation, research and development, will allow us eventually to come up with much better drugs. So I think that's like the most optimistic scenario. On the other hand, I can't help but think that the reason that companies are investing so much money in producing these kind of marginal products with marginal improvements is because they can, because they're getting high prices. And maybe if we raised approval thresholds, they would, not withdraw investment in this segment, but they would shift investment to possibly more, find more productive, better products.
Oh, it's on. David, could you talk for a minute? So, what about the idea that if you have, say, more biologically targeted, and again, biologically molecularly targeted approvals that would get around here's a first-line, second-line label here that might create more head-to-head competition, and also think about different forms of IP. For instance, if you had the ability to repurpose an already approved FDA drug, get approval for a new cancer indication, then compete for a limited amount of time with patent protection, you could have a variety of different types of IP competing against each other. And of course, one of the side effects of getting really good data for smaller cohorts of patients, because the average can mask really nice outcomes, is of course the companies are then looking at smaller and smaller cohorts of patients. The orphanization of cancer is just at the very beginning. But with that in mind, do you think it's possible, and I know that you've probably talked a lot with Ernie Byrne about this at MIT New Digs, you can move into a system where you develop a conversation about value and cost of development and a targeted population, move to market quickly, collect real-world data on outcomes, and then price evolves as the product, you gain more experience with the product.
Okay, sure. So, and I totally forgot to mention, I had it written in my notes, but Paul Howard, who's our last and greatest speaker today, had a really good editorial in the Wall Street Journal on this subject yesterday, so I urge you to check that out. Let's see, so, I think that, it's in some ways it is unfortunate that one of the side effects of the conversation, of the criticism that drug companies are getting about drug prices, is that they feel they have to set the price very high initially, because once the drug is approved and it's out there, they're not going to have much room to increase it. In fact, I think that what we'd really like to see is, they should have room to increase it if it turns out the drug is better. And so there's a drug, Imitinab, that's the drug for leukemia. They're the manufacturers taking a lot of heat for increasing their drug pretty rapidly over time. But that's a drug where, when it was approved, they had no idea how well it would work. And it turns out, it's better than their wildest expectations. And that's a case where you'd say, well, I'd like that manufacturer to be able to reap the rewards of the product they invested in. Increasingly products are being approved for narrower segments of the market, as you said. There are genetic markers, well, they'll say use the drug in this population instead of that population. I guess I'm a little unimpressed by that. I think clinically it's great, but in terms of kind of the economics of the industry and pricing, I don't really see the distinction between that type of marketing and approval and what we already have. I mean, we already have, you have a drug approved for kidney cancer or colorectal cancer, and with genetic markers, you're just slicing the market a little bit smaller. But I don't see how that's really going to kind of fundamentally either change the pricing of these drugs or the value of these drugs.
Sorry. I want to make 2 points. Number one, I'm going to go back again to the cancer, the breast cancer, and I know for a fact that established cancer drug for breast, when it has the generic, the patient refuse after being for 2 or 3 years to move to the generic. So there's no incentive of the brand name to come down. That's one big issue because the patient is very dependent and psychologically. Second question, I know for a fact that antibiotics made in the US cost less abroad, i.e. Europe and Canada. Have you looked on the anti-cancer drug, which I know for sure made in the US are cheaper in Europe?
Sure. So another issue with generic versions of anti-cancer drugs and specialty drugs in general that are administered in a physician's office is that physicians in some cases will make less money on the generic version. And so there's a great paper by Rina Conti that came out that showed then when a generic version of a colon cancer drug came out, physicians, instead of increasing its use, actually switched their patients to other types of branded colorectal cancer drugs where they make more money. Yeah, I think... okay, I mean, right. I'm sure there are oncologists who try to do the right thing too. No, I'm not trying to be facetious. I know that there are a lot of oncologists. I speak with them at Emory and elsewhere who are very concerned about their cost their patients face, the cost to society, and they're trying to bring that down. Yeah, I think if you look at for any drugs, be it antibiotics or anti-cancer drugs, they cost less abroad. In the case of antibiotics, I think it has to do more with kind of the lower barriers they have abroad to entry by generics. There are a lot of companies in India and elsewhere that produce these drugs. So I think that's something to look at, although you certainly have to be cognizant of quality implications. With anti-cancer drugs in Europe, the governments negotiate with the companies. They say, if you don't lower your price by a certain amount, we're not going to cover your drug. Patients in this country aren't going to get that drug. And they've been somewhat effective in using that bargaining power to bring down prices. I don't think that would be a great idea in this country, but that's certainly a tool that you could consider.
Hi, David. Great talk. Scott Cantor, MD Anderson Cancer Center. I really appreciated the analyses that you're doing, and I'm wondering if it's just coincidence or am I cynical and that the pharmaceutical companies have their own health economists doing the analysis. I see that in looking at this chart, Exhibit 3 you got up there, that if you did the incremental cost effectiveness analysis, it comes out to about $50,000, $60,000 per life year gained. So are they pricing these drugs so that way they're just barely cost effective, so that way when it comes time to do the analysis, that it turns out that, sure, these are cost effective, and then we can make a reasonable argument that they should buy it?
Right. So I think they definitely do that in Europe. I don't think in the US they do that so much. I mean, I think they try to get the most they can. And I mean, there have been cases where pharmaceutical companies have come in and said, we want to set a reasonable price, and they've been criticized by investors for doing so. They said, you could have gotten a higher price and higher profits. You're not serving your shareholders.
Simple question. How does the price that the company sets for the drug compare to the cost to bring it to market? I mean, they have to go through a lot to bring it to market, but it sounds like you got some really extremely high margins just because of some precedents. Right. So
there's a group in Tufts that tries to calculate how much it costs to bring a drug to market, and I forget what it is. It's a really high figure. It's in Paul's editorial, I think. But companies earn high profits on these drugs. That's why investors, if you go to the American Society of Clinical Oncology meeting, there's a separate investors conference alongside it. I mean, people want to get in on this action, so they earn high profits. But I don't think you have to go back for the reason they earn high profit. This is not like a mistake. This is not error of the market. They earn high profits because we want them to, because we give them a monopoly via the patent system. So you can kind of have your cake or eat it too in terms of having innovation or not. But high profits kind of come with the territory if you're going to give new drugs patents.
So I was a little surprised by your list of solutions that you didn't mention rationing at all. So it seems like an obvious solution to reduce cost is to not give these drugs to people over 90 or over 80 or with comorbid conditions. What do you think about that idea?
Right. Well, I mean, so I guess I wouldn't have put it up there, because it's not going to fly. I was trying to limit it to things that are, kind of in the realm of feasible. So I guess as rationing as you defined it, I don't know that would do anything about the prices. That would limit the cost, the amount we spend on the drugs, but I don't think companies would lower the price unless you said the amount of rationing we engage in depends on. So if you tied the two, right, then you might get lower prices. I don't know. I mean, I'm just a little uncomfortable with policymakers making those types of decisions. And I think based on what we've seen with how in the few limited instances where Congress has intervened in Medicare coverage and payment policy, it's always been to increase the generosity of benefits, to criticize Medicare for withdrawing coverage or not covering a new medical technology. And so I just don't know in our political system how that would fly.
So don't they ration care in Europe? And maybe that's the reason the prices are
right, yeah. So again, they'll say that, they engage in lengthy negotiations with the drug company. Here's the price at which we think your drug will be cost effective. If you come in at that price or below, it's covered, otherwise not. Even there, they've had some difficulties with adhering to that system. In Britain, they set up a separate fund to pay for cancer drugs outside of normal channels because of political blowback. But yeah, that's what they've used to be successful in lowering prices.
I'm going to venture beyond just cancer drugs, but you follow this literature better than I do. I hear arguments that sort of for-profit drug companies benefit so much from the research dollars by NIH, either directly at NIH or that they send to universities, and so that should be factored in terms of the prices that they're receiving for their medications. I don't know if you followed that issue.
Right. I don't know. I think it's there's some appeal to that. I just worry about the ability to clearly distinguish when you have a new drug approved. All right, this is the amount of the, this is, if you kind of quantify the innovativeness of the drug, this is the amount that's due to the NIH, and this is the amount that's attributable to input by the pharmaceutical industry. I just worry that would really dampen down on research and development and be just an administrative nightmare. I haven't heard anyone talk about how you'd actually operationalize that concept.
Okay, so my question, and I'm going to preface this by saying I'm a physician but not an oncologist. You mentioned that the main, or I guess, consumer for a lot of these products is actually the oncologist, and their incentive is to prescribe the more expensive drugs. So I'm assuming that means they are getting a percentage of whatever the drug costs as part of their office costs. So why not make that a fixed amount? So whatever they infuse, whether it's $5,000 or $10,000, they get the same amount. And then wouldn't that incentivize them to act on behalf of their patients for a less costly drug?
Right, so Medicare has certainly tried to move in that direction. So what they do now is they collect data from manufacturers on the average sales price of the drug, and they pay the oncologist average sales price plus 6%. So the 6% profit margin is designed to account for the fact that, they have to make a little money, overhead costs, so on and so forth. But yeah, maybe we should reduce 6% to 3% or 2%. The 340 Drug B program is another area to look at. The Department of Health and Human Services recently proposed to try to scale back the 340B program. One of the reasons being that it allows some hospitals and physicians to earn very high profits on physician-administered drugs. I think that's a great idea, but there's a lot of opposition on the part of 340B providers to doing that.
Small one. On oncology reimbursement, I've never understood why we pay a percentage. Why don't we just pay a fixed amount?
Well, it is a fixed amount now, like for Medicare, right?
No, it's not 6%.
Why
not just pay $500 or $100 or $50
per what?
Per a treatment, because you're paying the overhead of the physician for ordering the drug and managing the drug and so on. That presumably is uncorrelated with the price of the drug. So why should we be paying a percentage of the drug price? Cost plus reimbursement doesn't usually work well.
Right. So just average sales price, or but
just an amount of money. This is the administration fee.
Okay, but would it depend? So
no, it would not depend in any way on the drug price.
Okay, and if a physician decided to use a more expensive drug,
he would get back. No, he'd get back his ASP. We could pay the Medicare would pay the drug company. Forget about the physician. It would just be a pass through from.
Okay, right. Yeah. So I think that'd be a great idea. Cut the. No, there's no reason that. There are perverse incentives inherent in the reimbursement system.
United tried to do something like that. Some of our small studies basically said, look, you can prescribe what we want. We're going to give you a fixed fee for evaluating the management of the patient. and they actually saw the total cost go down. It was a very small study.
Right. I mean, right. So payers are very, active in this area. Most of the demonstration projects that I've seen they're engaging in, including the Medicare, I think it's oncology practice model, they continue to separately reimburse the drugs. So I think they'd eventually love to kind of tamp down on that, but I haven't really seen any models where they're saying, here's $20,000 to treat this patient, use whatever drug you want, we're not giving you any more or less depending on your choice. I haven't seen that so much.
You talked about smoothing the process for the approval of biosimilars by the FDA, but in terms of actual payment, do you think that any new biosimilars would actually help bring down the cost significantly? Because using Medicare as an example, I believe the new biosimilars payment model is similar to ASP, so you have the reference product and then you have the generic product that feeds into the price. But if they're both priced comparably at a higher rate, is it still actually going to be effective?
Right, so that's a key decision. I don't know if CMS has made that determination yet, but basically they have to say if a physician uses a branded drug or a biosimilar, will we pay the same amount, or are we going to pay less for the biosimilar? Are we going to set the payment rate in the middle of the two? That's going to have a key, that's one of the key decision on the success of biosimilars and their ability to lower costs.
So over here, I'm Heidi Russell. I actually am an oncologist, but a pediatric oncologist, so kind of a limited field. But so I would propose a different policy, which would be to actually limit advertisement of the new drugs, because many times the patient wants the drug, and convincing them that they actually want the drug that's been around when they are seeing on television or wherever ads for this new novel thing to please come talk to your physician about, especially in a life limiting scenario. It is actually kind of difficult to get them to commit or be willing to take a less costly drug when they're being told in the media kind of thing, because media works and advertisement works, that, oh no, they really want this new thing. So that is a place which would put which could be a policy change.
Yeah, so the American Society of Clinical Oncology is undertaking a big initiative to make oncologists more sensitive to the price of drugs, to make them more sensitive to patients' out-of-pocket costs for these drugs. Yet when I talked to oncologists at Emory and I asked them, well, is this an issue you guys talk about? And the universal reaction is generally, A, they don't feel comfortable talking about costs with patients, and B, when patients do bring up drugs and costs, it's generally they want the more expensive drug. So kind of echoing what you're saying.
Picking up on your comment that I'm back here, that it's difficult for drug companies to raise prices. Am I correct that some existing multiple sclerosis drugs price increases occurred, and how did they justify that, if I'm right?
Yeah, I'm not familiar with those. I mean, it certainly does happen. I think in today's environment, though, companies are setting their prices with the idea that this is the price, maybe we can raise it a little bit for inflation, but this is the price we're going to get from now until our patent expires. We're not going to be able to raise the price over time.
Thank you. I'm not a physician. I'm actually a healthcare banker with Bank of America Merrill Lynch. I'm Tim Madison. I cover a 4-state region. But my question is this, and to kind of revisit the 6% based on sales that the oncologists get back, is the treatment for patients different for each kind of drug? I'm trying to understand why they get 6% of the sales price back. I know we all are too, because it just seems like an obvious area where there's a disconnect. If the treatment is the same, there's no additional administration. Costs in the oncology practice typically are fixed. And a lot of it is in actually the machines and whatnot. So I'm just trying to understand that 6% kickback.
Right. We're getting upset about 6%. That was actually the reform that happened because it used to be a lot higher. 6% was movement in the right direction. But yeah, I think there are a lot of better ways, as Sherry said, to improve the payment of oncology that would reduce some of the perverse incentives inherent in the current system.
Has anybody ever explained why the 6%
Well, I mean, I think the idea, I mean, with most, contracts where a company A is paying company B, a cost, based on their cost, they say, we'll give you submit your invoices to us, we'll pay you cost plus a little bit more because you got to earn a little bit of a profit and you have overhead administration. So, I mean, that's the rationale for it. Right.
Thank you very much, Dr. Howard, for talking about this topic with us and helping us learn about what's going on in terms of drug pricing. Clearly, we're going to have you come back sometime again to teach us more. So we've reached our lunch break, and we have box lunches out back, and we do have a lunchtime speaker. Dr. Sherry Gleed is going to talk at lunch. So please take your time, go out and grab a lunch, and then as long as you're seated back here, I think we'll get started again around 12:15, 12:20. And hear Dr. Gleed speak. Thanks very much.